You're listening to Conferences on Lyme Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is June 20th, 2011, and I'm your host, Dr. Jay Portnoy. Our topic today, immunizations. Our presenter is Dr. Angela Myers. She's an assistant professor of pediatrics at the University of Missouri Kansas City School of Medicine and a member of the section of infectious diseases at Children's Mercy Hospitals and Clinics. Myers is an assistant professor of pediatrics here at Children's Mercy Hospitals and Clinics. She's in the Department of Infectious Disease, and she's going to talk to us about immunizations. So go ahead and turn the keyboard over to Dr. Angela Myers.
Thank you.
Here's the wireless mouse. Thank you for joining us on Conferences on Lyme Allergy, Dr. Myers.
Thank you. Okay, so we're going to start today just by that. I just want to take a quick look at the pre-vaccine era and then kind of our current state in our country. So one of the kind of things I want to highlight in this table is that, as you see, before the vaccines, we had hundreds of thousands of cases of diseases every year. And if you look at where we were in 2006, we had a tremendous drop-off with vaccines related to this. And then if you look at the percent decrease, the main thing I want you to take away from this is there's only 2 diseases that we've absolutely eliminated that we currently immunize for, so I'm not including smallpox in this, but that we currently immunize for from our country, and that's diphtheria and paralytic polio. So we still see cases of measles, mumps. You can see with pertussis, we've had an 89% decrease, which is really good overall. But when you talk to people, and I want you to think about this kind of later towards the end of the talk, but when we think about people who are vaccine hesitant, they think that all these diseases are gone, and they're not completely gone. We still do see some cases. And overall, we've had about a 98% decrease. So I'm going to classify the vaccines for everybody really quick because I think it sometimes is easier to remember if you look at it this way, and that's the differences between the live and the inactivated vaccines. So live vaccines include rotavirus, MMR, varicella, yellow fever, influenza, and then the oral typhoid. While the inactivated vaccines include Hep A and B, polio, DTaP, Tdap, I put together, the pneumococcal vaccine, Hib, meningitis, HPV, also an influenza vaccine, rabies, and Japanese encephalitis virus, as well as an activated typhoid. And the ones with the red asterisk are the ones that are for travel. So let's just kind of touch on our history for a minute. The first smallpox vaccine was developed actually way back before that, but what came into law in 1809. And there were some people who became up in arms about this even way back then, and so there were some state refusals during the mid-1800s, and so we saw a resurgence of disease. Then in 1905, there was a landmark case that went to the Supreme Court that upheld public health law and enforcing compulsory vaccines. This is Jacobson versus Massachusetts. It was a real big deal, and it was found to be constitutional. So this is the first time that an anti-vaccine movement went against public health officials in a court of law and went to the Supreme Court. Then, so this set up precedents, and then over time, states began to develop mandates or have mandates in their own state written laws, and there were 17 states in the measles era during around 1969, which actually had a mandate to vaccinate. So currently, it varies state by state, and so there's different types of exemptions. All states have a medical exemption, so people that have a genuine contraindication from a medical standpoint can get an exemption. 48 of our states have religious exemptions, and then philosophical varies all the time, and so it varies by geography, and it varies even within states somewhat. So that's something you have to kind of look at online if you're wondering which states have philosophical exemptions. So smallpox was the original disease for which we developed a vaccine. The first variolation is thought to have occurred in between 1022 and 1063 AD, and it was used powder from ground up scabs and blown into people's nostrils. It became common practice by the 1700s, but at that time, even 2 to 3% of people who were vaccinated with the variola virus died. An interesting piece of that is that in 1777, so right around the time of the Revolution, George Washington mandated that all of the military folk get vaccinated, which is something that still happens today. All of our military personnel don't really have a choice. They all get vaccinated for the vaccines that we give. Then Edward Jenner came along in 1796 and discovered that the milkmaids were not getting smallpox because they had immunity related to cowpox, and so he used fluid from the cowpox pustules to do widespread vaccination during this time frame. But then later, a drug company by the name of Wyeth developed the live vaccinia virus vaccine, which is different genetically from the cowpox and the variola virus. So it's a different virus, but it's related enough that it prevents smallpox from developing. And the first school mandate from that came in Massachusetts in 1855. Again, like I mentioned in the previous slide, anti-vaccine groups sprang up, and this became a major issue even way back then. The main side effects from this vaccine were auto-inoculation. So people were immunized in the shoulder, and then they could auto-inoculate other parts of their bodies and then get disseminated disease. Myocarditis and encephalitis did occur rarely. In 1972, we stopped vaccinating widespread because we had eliminated the disease. But the last person to have been noted to have died from smallpox was a woman by the name of Janet Parker, and she was a researcher in an anatomy lab in the University of Birmingham in the UK, and actually accidentally inhaled it in 1978. So the way that the vaccine was originally developed, in 1805, a researcher in Italy discovered how to grow it in the flank of a cow, actually. Then widespread publicity kind of developed about vaccine production as this was presented in kind of the mid-1800s, and it spread. This idea kind of spread, and so more and more people began developing it. So by the time World War I came around, most people in Europe were smallpox-free. By World War II, we were able to interrupt transmission in all of Europe and North America. And in the 1940s, a stable freeze-dried preparation had been perfected. This was how they grew the virus to make the vaccine. So moving on to the next disease, I wanted to give you guys just an overview of smallpox because of the history and because it was the first vaccine. But the rest of this is going to be more germane to today. So before the varicella vaccine was developed, there were 4 million cases per year and about 100 to 150 deaths in the U.S. annually. Does anybody know what those deaths were generally attributed to? Generally, it was related to secondary bacterial infection with group A strep, and development of fasciitis and that kind of thing. But certainly you can get pneumonia from varicella. So about 1 in 500 children were hospitalized and 1 in 50 adults were hospitalized. You can see that adults tend to get much more ill from this virus, and generally that was related to pneumonia. About a third of newborns who develop chickenpox will die because if they develop it as a newborn, they obviously have no maternal antibody. It's an extremely contagious virus. Transmission is not only contact with an infected person, but it's also airborne, and so that's why we have to use airborne isolation, and that's why it's also transmitted so easily. And just as with all viral illnesses, you're contagious 2 days before you really develop symptoms. So again, why it's so easily spread.
Do you know why adults don't do as well? I guess I would think their immune system would be more.
I think it has to do with the fact that it's overly robust, and they get even more ill. Kind of like when you have those, we've historically seen certain pandemics of influenza, how the healthy young adult tended to get more ill than the young child and the older person.
Their own immune system vigorously getting activated, and younger and older, their immune system is better. The more immune system you have, the more.
That's a very good question. So the vaccine was licensed in the U.S. in 1995, but keep in mind it had been available in Japan for about 20 years prior to that. It's a live attenuated virus, and it prevents about disease in between 70 to 90% of people, and serious disease in 95%. So it's not a 100% vaccine, and people that get the vaccine still get disease. This is part of the reason we started recommending 2 doses in 2006. So they found that it wasn't good enough. After having quite a few years of just giving kids one vaccine, we realized that it wasn't enough and that we needed to do a second dose. About 15 to 20% of people who have the vaccine will develop chicken pox. Generally, they have no more than 50 spots, and they don't develop fever, so they're pretty not ill, but they can transmit the disease still. Adverse reactions that occur to the vaccine are similar to what you see kind of with a lot, with the redness and soreness at the injection site. That's pretty typical for most vaccines. But another 5 to 10% of kids will develop a mild rash. And so this is, which is usually only around 5 spots, and it's kind of within this 1 to 3 week window after the vaccine. And so it's different than the kids that get vaccine and then develop chickenpox. It's kind of an extra 5 to 10%. So like 15 to 20% will still get chickenpox, and another 5 to 10 will get this little mild rash with just a couple of spots, if that makes sense. About 15% will have a fever, and febrile seizures occur in about 1 in 1,000. And so the interesting thing about this is, I don't know if you remember a few years ago, a lot of research was done, and they developed the MMRV vaccine. And so that was thought to be really wonderful because it was just one shot instead of 2 shots. Well, what they found in post-marketing surveillance was that and they compared kids that just got MMR and varicella separate to kids that got MMRV. The kids that got MMRV at that 1-year age mark were twice as likely to have a febrile seizure. So MMRV is no longer recommended at that 1-year age mark. It's only recommended at the second shot, at that 4 to 5-year shot. And then encephalitis and ataxia has been reported, rarely related to the vaccine or temporarily related, but a causal association is generally not found. And so that's really hard to prove anyway. But it doesn't seem to be that that's really much of a factor. So people that shouldn't get the chickenpox vaccine include people that are allergic to gelatin and neomycin, and that's one of those things that's always on board. People that have T-cell deficiency, so whether it's inherited, they're on T-cell suppressive therapy, or they have leukemia, active leukemia, or active cancer in general. But B-cell deficiency is okay. It's okay to get this vaccine if you have B-cell deficiency. The other thing you have to think about is with blood products. You have to delay, and I was intentionally vague on this slide because it depends on the blood product. If it's packed red blood cells, it's about 3 months. If it's IVIG, it depends on the dose. If it's IVIG for Kawasaki disease, it's 11 months. So it depends. However, patients that have HIV and have a CD4 count greater than 15% can get the vaccine and should be vaccinated. Yeah.
Is the IVIG question because you're just worried that they're not going to respond to
Correct.
it, so they need to report it to have an adverse reaction?
Yeah, yes. It's just that they're probably not going to respond. So that's why there's a table in the Red Book that tells you any type of blood product the patient might have received and how long you have to wait to give them MMR and varicella vaccine.
What if they're on IVIG for B-cell deficiency?
Well, it becomes a problem. Then you probably, if they're getting chronic IVIG, you have to know that they're probably just not going to respond to the vaccine.
Yeah, like that kid that we had has XLA, he has 0, like IgG, and there was 0 in it, and a lot of them, if you gave a vaccine.
But you're probably giving him. You can always just test them for varicella antibody because you're giving him. You're just giving him a pooled product. You're not giving him, right?
Right.
So the shot is.
If you're giving them IgG, doesn't make any itself. If you gave them a vaccine, how would it help?
Well, there's, the discussion I've heard is it you're still getting a little T-cell something going, and it's going to be worth it, even if you can't monitor it by a B-cell response. And I don't think it's known, but I've heard people sort of throw around that question, and I think a lot of people have chosen to still at least try to get the vaccination.
It's not going to hurt.
It's not going to hurt. So, for polio is the next one I kind of wanted to mention, and that it's a really interesting disease, and it's something that I've never personally seen, and I would wager that none of you guys have either. There was a major epidemic in our country in 1916 that led to 16,000 deaths and 27,000 children paralyzed. However, disease actually didn't even peak till the 1950s, and I've heard tons of stories from people. One of my partners, Chris Harrison, who was around during this time frame, who was a kid, said it was widespread that parents did not let their kids go to public swimming pools, did not let them play Little League ball, did not let them do all kinds of things in the summer months because they were just so convinced their child was going to get this disease. It was just, it really was one of the first kind of diseases that really caused widespread panic, in our country. It's transmitted from the contact of infected schools, so it's a fecal-oral transmission. And it causes a range of symptoms. And so this is what's so interesting. Polio causes so much panic, but 95% of the time it doesn't cause any problem when you contract it. Only about 4 to 8% develop a fever and sore throat, and even a small portion of those will get meningitis and paresthesia and then get over it. And then an even smaller, so 0.1 to 2% develop flaccid paralysis. And two-thirds of those will have some residual paralysis. It's now been eradicated in the U.S. Like I said, it's one of the 2, diphtheria and polio, that are completely eradicated in addition to smallpox. But it's still common in other countries, and it's imported. So India, Pakistan, like Kyrgyzstan, one of those, it still has cases of polio that it's been a problem, and some places in Africa too. So we've had 2 different inactivated polio vaccines that were licensed. The first one was in 1955, and that's, of course, a killed vaccine, and then the second was in 87. In between that time was the live attenuated one that came out in 1963. So what happened was the original one in 1955 came out, people got it, and during that same time frame, people continued to study it and look at the vaccine and wanting to try to make a live attenuated one, because the first one wasn't all that immunogenic. Okay, and so a bunch of people studied and developed this live attenuated vaccine, and then it became widely spread used in the 1960s. Well, a couple of different things happened. They realized that some people converted that the attenuated vaccine converted the wild type back in the human body and caused paralytic polio in a small number of children, but happened. And then possibly the bigger thing that happened, and there's a book written about it by Paul Offit, and he's at Children's Hospital of Philadelphia. It's called the Cutter Incident. And what happened with this Cutter Pharmaceuticals was a company, and they accidentally messed up the attenuation process. And we're talking like 24 passages of these cell lines. I mean, it's a pretty big process. And they sent a whole shipment of vaccine out that wasn't attenuated properly, and a bunch of kids were affected, and some of them died. And there was a big lawsuit. It was a huge, huge deal. And so then this race was on to develop another more immunogenic and activated vaccine, and so then that's what happened in the 1980s. And so all of us, when we were kids, got the live attenuated, and then there was this big paradigm switch in the late 80s to early 90s. Back to the inactivated.
So is OPV, is that still here?
It is not used at all. It has not been used at all since, I think, 1990.
Even in the World War I?
It is used, so that's a good question. So it is used. It is used in Mexico. It is used in all the countries that still have polio that they're trying to eradicate polio, because it is an excellent vaccine. It creates very good immunity, and it creates really good herd immunity, because in places where there's not great clean water sources, you think you're shedding that virus through your gut. And so all the people surrounding you are exposed to. So it's actually a great vaccine, but it has this small risk factor of developing wild-type disease from it. And so we were able to develop a better vaccine and give it. The other feature that's nice about giving the oral in developing nations is that it's just so much easier to get. It's on the sugar cube and you put it in the mouth, versus having all this vaccine handling and storage with needles and having to keep it maintain the line. So there's plus and minuses with it, but it is used in other countries. We give 4 doses in our country, along with the rest of the childhood vaccines, 2-4, and then between 16 and 18 months, depending on when the pediatrician decides if they want to break them up or give them all around that 12-month mark or not, and then again right before kindergarten. Usually just redness and soreness at the injection site. It's an extremely well-tolerated vaccine, but again, allergy to neomycin, streptomycin, and polymyxin B is the contraindication. So you'll see that kind of repeated, those allergies. This is just a couple of pictures. The 2 upper, one is India, the one is in Africa, the 2 upper ones, and then the main one is a picture of a child in an iron lung, which is what they used to have to do in kids that developed diaphragmatic paralysis related to polio, and they would keep these kids in these machines for weeks on end with really very little ability to care for them. You see there's a little hole you can stick your arm in, a little window you can look in, and that's it. Because this was before ventilators, and they had no other way to help these kids breathe. These are just pressurized tubes. So Hep A is also known as the foodborne hepatitis. It was the most frequent type of hepatitis in our country until 2004, but it's really, really gone down with the advent of this vaccine. We used to see about 20,000 cases per year. Again, this virus is found in the stool, it's fecal oral. You think about, I always tell people who kind of question getting this vaccine, if you ever eat out in a restaurant, then this is an important vaccine to get because you've got no control over your food handlers. And people, that kind of brings it to the light, oh yeah, I guess I don't have control over my entire environment all the time. Symptoms of Hep A, usually fever, belly pain, lots of appetite, fatigue, dark urine, jaundice, that kind of thing. And believe it or not, even though people have kind of thought of it as a lesser of the hepatitis virus because it doesn't cause chronic disease at all, 100 people would die every year from it because it can cause acute liver failure and people can die. Interesting thing about hepatitis A too is that young children under the age of 5 who get infected generally don't have any symptomatology whatsoever, not jaundice, not anything, and they're the ones that then pass it on to the older people in their family, and so they're the ones that get extremely ill with it. And so it's a really big deal vaccine that we talk about in people who are going to travel to a foreign country or are internationally adopting, because oftentimes those kids that they're adopting are infected and then they can bring it back and infect the rest of the family. So it's a big topic of discussion in those settings too. So it was licensed in 1995. It's also a killed virus. It's really good at preventing infection. So it's recommended at this point everyone greater than a year of age, and it's a 2-dose vaccine series given 6 months apart. When it first came out, it was just recommended for high-risk people, and so they did it kind of in stages. It was recommended for people who lived in areas that were highly endemic, and there were kind of spots in the U.S. The southeast was a big area, and then people that were like Alaskan Native and American Indian and things like that. And then they realized, okay, that's not enough because we've not, tamped it down enough. So then they said all people over the age of 11 or 12, like all teenagers and adults. And then they realized, okay, we still have this little cohort of small children. So it's really, it's been an interesting one to watch how it's marched down over the years to now just include everybody over a year of age. Up to half of people that get it will develop pain or swelling at the injection site, but very few have any fatigue or fever. So it's really, again, a well-tolerated vaccine. Hepatitis B, the other hepatitis that we can vaccinate against, is spread by serum, semen, and saliva, are the 3 S's. This also has symptomatology dependent upon age, just like Hep A. So if you're under a year of age and you acquire hepatitis B, less than 1% of the time when you develop symptoms. Between 1 and 5 years, about 5 to 15%, and then if you're over 5, half the time you'll acquire symptoms. So it's, again, one of those viruses that doesn't disproportionately affects older people. In addition to that, being dependent upon age, it also causes a spectrum of disease, from just a mild subacute illness that you then get over and you don't develop chronic infection, to having actual clinical hepatitis with jaundice, to then developing fulminant hepatitis, the need for, and death. The other interesting thing about hepatitis B, which doesn't occur with A, is that you can get extraintestinal manifestations. So arthralgias can be really prominent, and then Giannotti-Crossi syndrome, or the papular dermatitis with it. It's one of those things that you can see, sometimes on boards they ask about Giannotti-Crossi. So this vaccine is interesting because currently, I don't know why that's on there, it's the only vaccine that we give at birth. The important thing with that is that we have to know if mom's Hep B status. So it's one of those things that you absolutely have to know before you give the baby the vaccine, or at the time you give the baby the vaccine, so that you know that you need to give them HBIG. If mom is Hep B positive, you can't just give the baby vaccine. There's a 90 to 95% response rate with Hep B vaccine, so it's actually quite good, but not everybody does respond. And so, generally, we don't recommend just testing kids, to see if they did respond. I mean, we operate under the assumption that they did, but if they're found to have not responded, you repeat the second series. If they don't respond the second time, that's it. You don't continue any longer. There's some thought out there that they have some low-level immunity that we just can't quantify, but because you don't do a third round. The interesting thing about this is really important in kids who are liver transplants and other things like that. We see this often where they don't respond, and we give them their second series and they still haven't responded, and the liver guys are pretty worried about it, but you don't give a third one. again, pain and fever are the big adverse reactions here, and anaphylaxis is really rare. So I'm going to talk about diphtheria, tetanus, and pertussis together since they're the same vaccine, or they are all together. Diphtheria, again, is like polio, is the one other thing that is no longer, that we still immunize for, that's no longer seen in our country. But it caused severe neck swelling, and so you can see in this child, this is what they call bull neck, where the neck is like just part of the face and almost really not even a separate entity. You can develop membrane formation in the throat, which obviously causes breathing difficulties, and it used to be a surgical emergency. The bacteria itself makes an exotoxin that can also cause myocarditis and nerve damage. So prior to the vaccine, about 1 in 10 children with infection died, either related to completely occluding their airway or myocarditis. In the 1920s, we had about 150,000 infections with about 15,000 deaths. So it was a pretty prominent disease and pretty scary for people. For tetanus, we still see tetanus in our country rarely, but it does occur. Infection occurs usually from exposure to an open wound, so a cut, a puncture, a scratch, an animal bite, or burn. Additionally, neonatal infection occurs related to cord stump care. In fact, I took a phone call about a month ago from one of the hospitals in Joplin, Missouri, this before the tornado, and the doctor that called me said she thought she had a patient with neonatal tetanus, a 4-day-old infant, and they were Mennonite. They're a Mennonite family, and the mom is not immunized. Nobody in the family is immunized, and they had I think a lack of cord care at home. I don't know what they used to separate the cord, but the baby was having spasms and was really ill. So we still have it in our country. About 18 cases in 2009 were reported. It's usually gradual in onset and starts at the jaw and then spreads to the rest of the body, and can be so severe that it breaks bones because you can bend literally like that in that picture. About 1 in 10 people that develop tetanus infection will die, and usually disease only occurs in the non- or under-immunized population. So it's important to keep tetanus up to date because it's in our soil. The organism isn't going anywhere.
Once you get infection, what do you do?
You do give them vaccine, but you also treat them with antibiotics. Penicillin is usually the mainstay. This is a gram-positive spore-forming organism, and it's susceptible to penicillin. And you give them immunoglobulin, tetanus immunospecific called TIG.
Yeah.
Do you give them anything for the test, so they don't respond to like normal
That's a really good question. It's not in any other reading that I've done about like giving them like paralytic. Right. I don't know about that. That's a good question. That's those 3 things are the mainstay, but you give them you do a lot of supportive care with maintaining an airway and all of that. For sure.
You doing the treatment?
Well, and some of that's related to the fact that they're so far gone by the time they get, diagnosed. Not only so partly because they're probably in a rural setting and take a long time to get to care, to seek care. But the other piece of it is you have to be a really astute clinician to even think of this because have you ever seen tetanus? Right. Well, right. Yeah. So pertussis or whooping cough. It's still a common disease in our country, and it's also highly contagious, spread by droplets. The thing about whooping cough is that if you are exposed to somebody with pertussis, even if you are fully immunized yourself, you have an 80% chance of developing pertussis. Your disease will be modified. You probably won't cough 100 days. You may not have paroxysms, but you're 80% of the time you're going to develop the disease itself. It can also spread it to others. And people don't realize that about pertussis. The vaccine we have is good, but it's not great. And immunity doesn't last forever. So in older adults and children, generally they have more of a mild URI with a cough that doesn't quit, but not usually all the other kind of features that sometimes you see with pertussis. And so the piece of that is that it's really underdiagnosed in our country because people call it bronchitis or they call it whatever. You know, they don't call it pertussis, and they don't think about it, and they don't test it, and so on and so forth. The really important thing about pertussis is that it causes really severe infection in infants under a year, and generally they acquire it from their parent or a sibling who have it, who got it from wherever, and they're under immunized, or they may be immunized appropriately for age, but before you've had at least 3 doses of pertussis vaccine, so 6 months of age, you have really no good immunity to it. So 50% of infants under a year who get it need to be hospitalized. 1 in 10 will develop pneumonia. 1 in 50 will have seizures. 1 in 250 will have brain inflammation. And we have 10 to 20 deaths per year in our country. In a minute, I'm going to show you what, yeah?
Go ahead, sir.
In a minute, I'm going to show you a slide about what's happened more recently. So before vaccine, we had about 150,000 cases a year. In 2005, we had our highest number since 1959, which was 25,000 cases. Actually, it was a little more than that. It was closer to 26,000. And in 2009, we had 17,000. And keep in mind, we just had that recent outbreak in California that was craziness. Immunity, again, immunity decreases over time. And now there's a new vaccine, which is how we're trying to combat the decrease in immunity, which is the Tdap, licensed in 2005. It's recommended as a booster in teenagers and adults, and it's approved for more than 7 years. So it gives you your tetanus booster, which you need to have every 10 years, and then you also get this pertussis that we know has waned by the time you're 11 or 10.
How often do you re-immunize with Tdap?
So right now, it's only suggested that you get it the one time and then you do TD, but it's probably over time that's going to change. It's just that this hasn't been out long enough to have enough long-term studies to say when you need to get Tdap again. But so watch for that, because I think in the next few years they're going to say, okay, in 10 years you're going to have to get a second Tdap.
So it's not every 10 years?
Not right now. It's just the one time, and then you do TD.
Well, what is the deal with when you have a baby?
You get a Tdap.
You know, have not knowledge.
Mm-hmm.
In my residency clinic, I always say Tdap because that's their adult. The adults never
Had it. Probably they had it.
So if they needed a tetanus shot, I'd just give it.
Adults are pretty uniformly under-immunized.
Then a PD is given.
But most of them probably haven't had it.
That's what we did. We were giving them Tdap, I think, every 10 years.
So it hasn't been out. It's only been out.
That was 2005.
It wasn't even around when I was
Yeah,
doing
we started.
So they couldn't have had 2. Just,
Yeah.
hasn't been even out 10 years. So, right. So this is how whooping cough has looked like in our country. So you see the peak. Whooping cough is a really interesting disease in that it cycles every 3 to 5 years, so you'll see a peak during that time frame, okay? The wholesale pertussis vaccine was introduced in the 1940s, so you can see where there's a big decline after that. And then in 1991, that's where DTaP, or the acellular pertussis vaccine, was licensed, and so there's just a small, increase after that. Part of that is because the wholesale vaccine was a better vaccine in its immunogenicity. It had longer-term protection, and it was more protected. More people seroconverted with it than do the DTaP, but it had more side effects, and so that's why it's gone. This is just another slide showing what's happened since then, so you can see where there was this second rise in 2009 with pertussis cases. So there's one vaccine for diphtheria, tetanus, and acellular pertussis altogether. It's a kill vaccine. You get 5 doses, 2 months, 4 months, 6 months, between 12 and 15 months, and then again at kindergarten age. So it's only 80 to 85% provides protection to pertussis, but 95% for diphtheria and 100% for tetanus. So you can see already that pertussis at best is only 85%. 15% of the population don't really develop much immunity to it. And then on top of that, your immunity decreases over time. The typical side effects with DTaP are local reaction with pain, swelling, and redness. A small number, so 33% will have that, but a small number will develop what's called a large local reaction after the 4th or 5th dose. And usually it's after the 4th, not always, and it lasts a few days, so the whole arm swells or the whole leg swells. It is not a contraindication to giving the next dose. So if it happens after the 4th dose, you still give the 5th dose. Okay? That's an important thing to know because people get really freaked out about it. About 5% will develop a fever greater than 101. And febrile seizures, the hypotonic, hypo-responsive episodes, higher fevers, and prolonged crying that was seen with the wholesale vaccine are very rare with DTaP and not really seen much at all. So with the whole cell vaccine, which is, again, no longer used, about 1 in 3,000 would develop fever greater than 104. There was a small cohort of kids that would have this prolonged crying episodes for longer than 3 hours. About 1 in 14,000 would develop a febrile seizure, and then about 1 in 1,750 would develop these hypotonic, hyporesponsive episodes that were pretty scary, and although they would resolve, this was a big impetus to get rid of this vaccine and have the acellular. So the people that shouldn't be immunized with DTaP include people that develop an immediate allergic reaction after the vaccine, of course, kids that develop encephalopathy within 7 days. Again, this isn't really much seen with the DTaP, but with more seen with whole cell vaccines. The DTaP vaccine was licensed in 1991 for older children and 1996 for infants. So I'm going to talk about measles, mumps, and rubella together, and then their vaccine as well. Measles is represented by fever, cough, coryza, conjunctivitis, and then the characteristic rash that people call morbilliform, and Koplik spots. About 1 in 20 will also get pneumonia with measles. 1 in 1,000 will develop encephalitis, and 1 to 2 in 1,000 die from infection. It's also airborne, so it's very highly contagious. And again, like varicella, you're contagious before you have symptomatology. Mumps generally causes parotid gland swelling, sometimes unilateral, sometimes bilateral, fever and headache. About a third of the time, they only have respiratory symptoms and not big parotid glands, so it's harder to recognize in that setting. And they can have other organs involved as well. About half the time you'll develop a CSF pleocytosis, but only 10 of those will have a frank aseptic meningitis with headache and feeling meningitic, stiff neck and all that. About 50% of boys post-puberty will develop orchitis, but very rarely does it lead to sterility, but it does happen. About 2 in 100,000 will develop encephalitis, and 1 in 20,000 deafness. So that's really the most important, one of the most important pieces to mumps. Rubella is also known as the German measles or the 3-day measles. It's a milder rash with fever, adenopathy. Adenopathy is a bigger feature. So if that came in a question to you and they talk about the adenopathy or they highlight the adenopathy, then it's rubella and not measles. The biggest risk, for rubella is the congenital rubella syndrome, which is really why we vaccinate people and why it's important to know if mom's immune when she has a new baby. And it's spread by droplet transmission.
You'd be amazed at how many kids who look like that get sent to the allergy clinic to see what the allergy was that caused that rash.
Yeah.
It's amazing. I don't know. Because people just aren't thinking of it. They're not used to it.
Right, right. And it's not seen all that often, but it still does occur, in some outbreak settings.
I know, but instead of thinking mumps or measles or rubella, they think, well, it must be an allergy.
Well,
right.
But you have to think about how many younger practicing clinicians haven't ever seen it.
I've never seen it, so they've seen allergies, so they send them to us. That's why we need to know about this stuff.
Sure.
What are your statistics that said, there's only one case of congenital rubella syndrome? Is it cost effective to test, every pregnant woman in the whole country to find, that one, you know what I mean?
Well, so we find, that's a good point. But we do find women who are not immune, just not that they're just, luckily there's very little rubella in our country, so they're not exposed while they're pregnant. So the reason is because we want to immunize them after they have that baby to make sure they become immune. Does that make sense for their next pregnancy?
Yeah.
That's why. I honestly don't know what the percent of non-immune women is. It's pretty low. It's certainly higher in population, immigrant populations that we see. They're a bigger proportion because in some countries they don't. So Mexico, they don't immunize against rubella. They just do measles. So, large portions of women from there are rubella non-immune.
I think a lot of, I would say privately insured women would probably get all the screening done before they get pregnant the first time. Get immunized.
I just feel from a public health perspective, it seems like we're
Pricey.
really looking for a needle in a haystack, so that's something you do on such a widespread scale.
If this was a disease that we completely got rid of in our country, then we could quit screening women at some point. But we're not there, and we still have some outbreaks.
Yeah, but getting rid of it in our country wouldn't do it because people fly.
We're getting rid of it worldwide. You're right.
It'd be like smallpox, where it's eliminated.
Worldwide. That's true. So the vaccine is made from live attenuated viruses, provides lifelong protection. For measles, the seroconversion rate is 98%, so it's quite good. For mumps, it's the lowest. It's 75 to 91. And for rubella, it's 95%. I don't know if you guys remember back a few years ago when we had the big mumps outbreak in Iowa. That was related to some of the college kids that only had one dose and not the second, and some of them actually had two. So 2 doses are recommended at this point, 1 at a year and then 1 at kindergarten. And the difference between this vaccine and the other vaccines where you get a kindergarten shot, those are called booster shots. So for DTaP and the other ones, that's called a booster. This is not a booster. This is a second chance of developing primary immunity. Does that make sense?
No.
You get an extra about 5% of kids by giving them a second shot that didn't seroconvert the first time.
I guess there's a lot of people my age who are not immune because they only got 1 shot. That's
Well, I don't know. Were you alive in 1957?
I was.
Then you're probably considered immune from
No, I actually didn't get measles.
Oh.
My siblings did, but I actually did not.
But because you didn't develop disease doesn't mean you're not immune.
I didn't seroconvert.
Oh, okay.
And so I was given the MMR when it first came out, but at that time there were no recommendations for a second MMR. So I stumbled on to getting a second MMR when I was in college because by then they had made that recommendation, and just by chance I heard about it and went to the health center where they gave it to me. But actually it wasn't health. They were doing it out on the campus, and they were just vaccinating everybody who was walking by. They were trying to just get everyone, even if they had it. They didn't seem to be worried about it. But that was the only reason I got my second vaccine. Otherwise, I could conceivably not have been immune.
Well, so that's what happened in Iowa. There were still a lot of college kids at that point that didn't get the second dose, and some that had that still got disease. So about 20% will develop fever, and about 5% will develop rash after vaccine. Thrombocytopenia occurs in about 1 to 30,000 to 1 to 40,000 children, and it is a known risk for MMR, and it's real. But the thrombocytopenia that occurs with disease is quite a bit worse, so it's thought to be considered an acceptable risk. Adenopathy will develop in a small number. Remember, that's related to the rubella piece. And arthralgias in about 25% of adult females. So women that didn't get their second dose at kindergarten age and then have to get a vaccine later, oftentimes will develop arthralgias, and it can be pretty significant, and it's related to the rubella piece of the vaccine as well. So again, severe allergy to gelatin or neomycin. This kind of comes up over and over and over again. Shouldn't get the vaccine. I've never seen a kid with that. Have any of you guys seen a kid with severe?
Yeah, we had a kid anaphylaxis to gelatin.
Yeah? Then there
in the form of gummy bears.
Really? That's interesting. Okay. Immunocompromised state. So kids who are undergoing cancer treatment, kids who are on chronic steroids, and then again, kids with HIV that have a normal CD4 can get the vaccine. This is the same for varicella. Recent blood products, and pregnant women shouldn't get it, even though when it's been inadvertently given to women who are like in the first trimester not known to be pregnant, nothing has ever happened. If you're going to give, if you give immunoglobulin for a traveler, if they're too young to get Hep A vaccine and you're going to give them immunoglobulin, then you have to wait 2 weeks to give the MMR vaccine. And that's actually not an uncommon thing for kids traveling under a year of age because you can't give them Hep A vaccine, and so but you can give MMR early, and so you kind of have to play with that a little bit and kind of just figure out the timing. I just want to mention real quick while we're still talking about live vaccines is that kids who are undergoing treatment for cancer who just are undergoing chemotherapy and then get off therapy, about 3 months is what you need to wait before giving any live vaccines. Kids who undergo a hematopoietic stem cell transplant, it's partially dependent on the type of transplant. So if it's stem cells, it's their own cells versus somebody else's cells and all that kind of thing. It's usually considered to be a year before you give any vaccines at all, and then about 2 years before you give a live virus vaccine. Again, taking into account people who have GVHD. So people, even if it's been that length of time and they've got pretty bad GVHD, you're going to even wait longer.
Do you immunize from scratch? Because like if you irradiated their bone, if you eliminated their own bone marrow, so that theoretically all the vaccines you gave them in life
are gone.
Those cells are now gone.
So you expect that they're gone. it depends. There's some debate about that, and there's some differences because they obviously got immunity from the person that they, depending on how
if
they.
they're giving stem cells, then those cells have to go through thymus school and learn all over again.
Right.
They don't have innate immunity. They have innate immunity, but they don't have any acquired active immunity.
So it depends. So it depends on the type of transplant you got. But a lot of people just start over instead of drawing so much blood to look for antibody levels to decide and that kind of thing. And then for organ transplant patients, that's the other kind of population I wanted to mention, you should try to give them immunizations a month ahead of time if you can. So if you can kind of plan that, it's better if they can get their vaccines pre-transplant. And for some people, post-transplant, they'll give vaccines about 6 months later, provided they're not on a lot of immunosuppression. They've not had any kind of rejection whatsoever. But that's, a big deal too, and that's got to be a difficult scenario. Rotavirus vaccine. So rotavirus is the most common cause of severe diarrhea in our country, but also worldwide. 100% of children will have had it by 5 years. In our country, it used to, before vaccine, 55,000 to 70,000 hospitalizations annually and about 20 to 60 deaths. But the death toll is, huge worldwide, 500,000 deaths. It's a much, much bigger problem, mostly related to the fact that they can't provide great supportive care. And that's just kind of a cool little picture of what rotavirus looks like. I thought that was fun. So there are currently 2 vaccines licensed for use. One is a human bovine reassortment, and it's 5 strains. It was approved in 2006, and it's a 3-dose schedule. And it's a funky schedule. So the minimum age you can give it is 6 weeks. The maximum age you can give it is 32 weeks, and not beyond that. And then it's given kind of on a 4-6 month window. But they're really, the way it was studied was really with these tight minimums and maximums, and that has to do with the original rotavirus vaccine, which was the rhesus monkey one that was in 1999, and that was pulled off the market because of the intussusception. And so the peak of intussusception is 5 months for infants, and generally, between 3 and 5, but generally at 5 months. And so that's why they have such tight restrictions on the minimum and maximums for this vaccine at this point. The human alone one is just one strain, but it provides much better cross protectivity than the human bovine one, and so that's why it's only one strain. It's a quite good vaccine. It was approved in 2008, so 2 years later, and it's a 2-dose schedule, so it's a little bit less. The contraindications to this vaccine, which are important to know, is the anaphylaxis to latex, because the stopper in the human strain one, the RV1, has latex in it, and then infants with SCID. So I don't know if you heard about in the MMWR, there's reports of infants that weren't diagnosed with SCID, got the rotavirus vaccine, then were diagnosed and developed severe rotavirus disease, and so that's been considered a contraindication. It is not a contraindication to HIV or to the HIV-exposed infant. And keep in mind that most infants who are exposed to HIV don't develop HIV, and also at the time in which you start the vaccine, you generally don't know because you're continuing to look at them and test them. And then spina bifida is a precaution, so you can't use the RV1 in the setting of spina bifida because of the latex piece of it. And then, although chronic intestinal disease or short gut is not a contraindication, it is a precaution. You have to think about that. But it's better to get the vaccine than it would be to get rotavirus and have really a lot of problems related to that. So I just want to touch on adolescent vaccines for a quick minute, and then we're going to shift gears. The meningococcal conjugate vaccine, I put it under adolescent vaccines, even though now it's approved down to age 2. It's recommended for all children greater than 11, anyone with a complement deficiency, HIV, asplenia, anyone who's having foreign travel, and anyone who wishes to decrease their risk. So really it's approved for anyone, although it's not widely spread use down to age 2 unless you've got a reason for it. It's okay to give in pregnancy versus the HPV vaccine, which isn't. And its only contraindications are people that have previous Guillain-Barré syndrome or have latex allergy. The HPV vaccine, there's two licensed vaccines. One is the 4-valent and one is the 2-valent. The 2-valent is the one that does not provide protection against genital warts. It's licensed between 9 and 26 years, and it's a series of 3 vaccines over 6 months. It is contraindicated in pregnancy because it hasn't been studied. And then those who have a hypersensitivity to Baker's yeast. Has anybody seen that? The Baker's yeast hypersensitivity?
It happens, but it's rare.
Rare. And the big thing with HPV vaccine is fainting, and that's kind of a true thing for most teenagers. It was originally kind of reported with HPV, and so you have to, and somebody who you think is high risk, have them be prone or have them lie down, and then they have to be they have to be watched for 20 minutes because they may pass out at any time. And so there were a lot of adverse events reported because of kids passed out and then hit their heads. So not really a vaccine adverse event, but things like that happen. And so there was a little bit of people getting up in arms about that originally when it first came out.
So the 26 years are kind of because you're after that point you're...
Well, so that's how long that's what age has been studied up to. I don't know if it's thought that it would be cost effective after that age either. So it was studied up to 26, but you have to think that this is an extremely, just like you mentioned, cost effectiveness. This is a really expensive vaccine, and so it's like a $600 for the full three doses, which if you kind of think about over a population is quite a bit of money, and so versus that influenza vaccine which is like $25. So I think that's a big stopgap too, and like you said, women over the age of 26 are probably lower risk.
They probably have to pay out of pocket if they would put it.
Yes, if they want it.
Probably their insurance probably won't cover it.
That's correct. That's correct. And in fact, a lot of insurances weren't covering it in the beginning anyway. It was a huge issue, and a lot of people in their private offices weren't giving it because it wasn't covered, and it was really problematic. So I know that's kind of hopefully that's going to get better. It's now been approved for boys too, and some people are routinely giving it, but not the majority of people because again, insurances aren't wanting to pay for it.
Insurance that they're wanting to cover for girls? No,
it's much better. Yes, yeah. So I want to talk for a little bit about a couple of adverse event reporting systems in our country. So the first one is VAERS, or the Vaccine Adverse Event Reporting System. It was developed in 1990 by the CDC and the FDA. It was a joint effort, and it's a passive reporting system. And doctors, patients, caregivers, anybody can report. It's not just medical personnel. If they get several similar reports around the same kind of theme, then they'll investigate to try to figure out if there's a cause and effect relationship. But it goes on to then a bigger investigation and more of a kind of a scientific study. So they received about 128,000 reports between 1991 and 2001 over almost 2 billion doses of vaccine. So you can see that although 128,000 sounds like a lot, 2 billion doses of vaccine, it's small relatively. Most of the time, fever, rash, swelling, and redness were the reports of adverse events. And the interesting thing about this, which is kind of what I wanted to highlight, part of the reason that the DTaP, we went from wholesale to the DTaP, is that the number of reports with the wholesale vaccine versus the DTaP vaccine has really dropped. And then similar decreases were seen in VAERS or in other reporting systems before VAERS when we switched from oral polio to the inactivated shot form. So the next one is the Vaccine Safety Data Link Project. It was also formed in 1990 as a partnership with managed care organizations. So this is different than VAERS, which is, again, a passive reporting, anybody can report. This is an active surveillance system. It's evaluating safety continually. They have data on about 5.5 million patients. And what it is it's different managed care organizations that have signed up to be a part of this around the country. I think there's 8 of them, and they continually follow these people. And it allows for rate calculations, and because they can look at the vaccinated and unvaccinated populations, they keep all these records on all these patients, which is different than VAERS because, of course, only the reports they're getting on people that are vaccinated. The next one is CISA, or the Clinical Immunization Safety Assessment. That was established by the CDC in 2001. It is developed by 6 academic centers with experts in a bunch of different fields, including ID and neurology and immunology and so on. And it's a registry for rare and serious events. They develop protocols and assist in the evaluation and diagnosis of affected people. So sometimes VAERS will then send CISA reports to these people on this committee, and then they will investigate and develop a protocol to kind of figure out how do you evaluate this patient, how do you determine what their diagnosis was, how do you manage them, and what would we do to look at whether or not this could be cause and effect. They recently completed a review of 99 people that had neurologic events post H1N1, and one of our ID doctors, Barbara Pahuch, who's our new partner, She just joined us in February. She's on CSAD. She was on it at Fellow, where she came from in Stanford. And so she's still on it. She just brought that here. So I just want to talk for just a few minutes about some misconceptions about vaccines that parents...
Start winding up.
Okay, that parents often talk about it when they have problems. So one of the things parents often will say is diseases were going away before we had vaccines because of better hygiene. So really, that's not the case. And if you look at my measles down at the bottom, you can see that until the vaccine was licensed, we really didn't have a sharp decline in vaccine disease. The majority of people who get disease have been vaccinated. Well, that's oftentimes true. So no vaccine is 100% effective, and if you looked at a measles outbreak in a school of 1,000, and there were only 5 children who were unimmunized and got disease, but there's 99% efficacy of the vaccine, that leaves 10 children at risk. So if all those 10 children got disease, then 10 out of the 15 children that got disease were immunized. Does that make sense?
Mm-hmm.
That there are bad lots of vaccines that are associated with more adverse events and death. So the FDA has the ability to recall lots if they need to. To date, no lots have ever been found to be unsafe on the basis of a VAERS report. So that's something that they absolutely look at when the VAERS report gets filed. Vaccine can cause harmful side effects, illness, and even death. Well, serious adverse events do occur, but they are rare, and there's no evidence to support that vaccines have contributed to any deaths since the start of VAERS. Vaccine preventable diseases have been eliminated from the U.S., so there's no need for my child to get immunized. There's only, again, 3 diseases that have been completely eliminated: polio, diphtheria, and smallpox. We have foreign travelers to our country that bring disease. We go travel foreign and bring back disease, and we have to protect people who can't be vaccinated because there's a cadre of children who can't be vaccinated. Giving multiple vaccines for different diseases at the same time causes risk of harmful side effects and can overload the immune system, and this is a really popular one right now. So 2 reasons to give combination. Give the vaccines early as possible because you develop protection earlier, and also there's fewer office visits, saves time and money, and less trauma for the child to have them more at once than drag it out for them. So here's the antigens and vaccine by year. In 1900, we only had 1 vaccine. It was smallpox that had 200 antigens in it. By 1960, we were at 3,200 antigens because the wholesale pertussis had 3,000. And in 1980, we were at 3,140. Even though we'd added, we were able to improve because we'd also gotten rid of smallpox. And then in 2011, we have all these vaccines we give: diphtheria, tetanus, acellular pertussis, polio, measles, mumps, rubella, Hib, varicella, Hep B, Hep A, pneumococcus, and flu. And we only have 133 to 136 antigens.
Because they're purified?
Yes. We're much better able to make them, and we're better to make them more immunogenic by adding adjuvants, which I didn't even talk about. And then finally, I think last but not least, is the vaccines and autism issue. Multiple studies have not found a link between any vaccine and autism. The original study was not only discredited, but that guy had some serious legal issues and lost his medical license. And there are many ongoing studies to try to determine the causes. So why have rates increased? Well, because doctors and parents are more aware of it, so people are getting diagnosed earlier, they're getting treatment earlier, and we've changed our definition of diagnosis as well. And then I just wanted to show you this. This was the most recent graph I could pull from the CDC to look at our up-to-date for up to 3 years of age for vaccines in our states, and we're in the 60% range in both Kansas and Missouri.
Of kids who are vaccinated?
Completely. By age 3.
All right. Well, we're going to have to stop here because we are over time, and Dr. Greenhut is waiting to give his presentation. But thank you so much
You're welcome.
This illuminating presentation. It was very interesting and quite relevant to us allergists. Thank you so much. So we're going to take about a 2-minute break while Dr. Greenhut and I get set up, and then we'll get back together and talk about component testing for food allergies. This is Conferences on Lyme Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri.
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.